right hip, it's
Yeah.
hard to get this angle straight here.
For sure. Yeah. Just need that right side to push forward.
Because it's so far this way that it needs to kind of come back this way to be able
Mm-hmm.
to get the proper, okay, cool.
Yeah.
Nice.
There's one, does anyone else have a question? I wanted to talk about one unrelated thing today.
I had a question. I had an Ober's test question.
Yeah.
But I don't. Is it okay if I ask it?
Absolutely.
Okay, so earlier this week, I was at the gym, and one of the physios, like a physical therapist who like works out of like the gym where I train clients, I asked him. He wasn't seeing any patients, and I asked him. I said, "Hey, can you do an Ober's test on me?" And so I got up on the table, and he did the Ober's test, and he says, "Oh, you're fine." And I said to him, I said, "But I felt I felt my pelvis tip forward. I felt my back arch." And he says, "Oh, and he was telling me that, oh, the Ober's test is about testing he's like, yeah, your IT band is fine. I'm like, what do you mean? Like, I felt my pelvis like shift forward. I felt my back arch. And he's like, oh, well, that just means you have like 2 degrees of hip extension. And I'm like, I got really confused because I don't feel like I have 2 degrees of hip extension, because I can do like the splits both ways, which that's like all the way to the ground, and that's like a lot of hip extension. So I'm really confused now about what the Ober's test like actually does and how to actually do it.
I think you should probably throw out what that guy said a little bit. I don't think he probably had a good grasp on what the Ober's test is and what it actually is doing. I would say the reason why we do the Ober's test is because it's basically just a giant compression test. Like, can you get all the compression measurements on one side of your pelvis? So the first part of the test is the hip extension test, as you have mentioned. So it's also a passive hip extension test at the same time, but it still matters. But I don't know where he got the 2 degrees from, especially if your back was arching. So if I see any sort of lumbar lordosis increase before I see that knee get to in line with the hip, then I'm going to call that a failed test, because they're using lumbar extension for hip extension at that point. And then my measurement is not going to be genuine after that. But I'm not sure. I just have no idea what that guy was really talking about with your hip extension. But the IT band, the Ober's test traditionally, before PRI started using it a lot, was actually designed to be a IT band measurement. So if you couldn't get your hip back and down, then they would say, oh, well, then this lateral hip musculature is really, really tight. Therefore, that's what's restricting you. And then that's just kind of the traditional, muscles dictate everything approach that we've kind of gotten out of a little bit.
Okay. That clears up a lot, because I left that guy's table feeling like, what just happened?
Yeah. I wouldn't pay attention to it too much.
Thank you.
So in PT school, you're taught Ober's test is a TFL length test. Like, that's just what they tell you. I actually emailed the journal that the original Ober article was printed in, because I was super curious, because when I was in school, one of my clinical instructors was arguing with me about what it did. So the original article says that if your leg doesn't drop, then you'd benefit from this procedure that this guy did where he released your IT band. And that's all the article said. It was from 1928. And then along the way, somebody said, oh, it's because your IT band's tight. So it's basically it's one of those things that you don't question if you're told it in PT school, unless you have this other perspective. So that's where he got the IT band thing from.
And that's a really good addition, Tyler. I'm glad you said that. In this book that, I've been talking about a lot more, they talk about the Ober's test. And they say, which again, I'm not sure I fully agree with. This book's really great, but there are a couple of things where I'm just like, But they say Ober's test, testing mainly the short AB ductors and sideline. In the vast majority, adduction is adequate. to allow the right knee to come close and actually touch the table, whereas left hip adduction is decreased relative to the right, so that the left knee comes to a rest at a variable distance up in the air, but consistently further off the table than the right one. And they basically say that is because of the reasons that you stated, Tyler, which I think, because this book came out, the first edition in the early 2000s, I think that's probably because it's just taken from that. But yeah, we know that it's not necessarily all about the TFL and IT band. Anything else on that, or any other questions? Okay, Doug, I wanted to talk about one thing, and this was going to be in the advanced program, but I was thinking about it. I think you guys read my message. You probably understand that the time to put into that program would just be wild right now. And so I want to wait until the next program is done, then maybe combine these two and whoever's interested into it at that point. The slides are almost done, actually. I want to put out the best possible product that I can. So, but I wanted to talk about one thing, and this is honestly probably one of the most important things that would have been in it. And it's taking the idea of the phases and combining them into one session or a single or much shorter time period. And this is sort of a thing I'm working on, and I don't have like a very like fundamental, like so much data to present on this, right? Because this is only something I've been working on for the past 4-ish months. So basically what you can do in theory is you can take someone through phase 1, 2, and 3. You just have to make sure that you sync things up correctly. And I find that this is effective for some people, but not all. I find that I'm still working on like what people this works for the best and what people this doesn't work for as much. But what you can do, for example, is if you can get someone to clear phase 1 measurements in an exercise or two, or you can make a dramatic improvement that leads you to believe that they can pass that, then what you can do is you can get a little bit more into phase 2 or phase 3 if that person is ready for it. So let's take someone, for example, they're a narrow, they're missing a little bit of shoulder flexion and hip flexion. If you can give them an exercise, maybe like the supine alternating cross connects, and then it clears up those measurements to the point where they pass phase 1. And then let's say they have a lateral orientation. At that point, what I would probably do, because that lateral orientation is probably driving some of their issues, is I would then probably think about, okay, well, what do I need to do first with a lateral orientation? We got their pelvis relatively neutral, hamstrings and abs, that whole deal. So if we can get them out of that anterior tilt, and then we want to deal with this lateral orientation, we took them back to here after that exercise, then we can think about maybe pushing them back to the left a little bit and beginning that process. So that would basically mean, let's get them to at least sense the ability to start pushing back to the left, but let's not make it the whole deal, right? So I've been working on this with some people. Like I've got a lateral orientation right now. We did exactly that. Supine alternating cross connects, a hamstring bridge, and then we went into a sideline right propulsion activity. And that person said that before, when we were doing, just regular phase 1 stuff, they felt like it wasn't making that big of a difference. But once we did that stuff, it made a dramatically larger difference. And I think it's not always going to work like that. Some people, the reason why the phases are laid out the way they are is because it's designed for, like, if I was doing this for the first time and just learning it, that's exactly what I would have wanted and needed to hear, because we can rush through the phases so quickly. We can rush through restoring the things we need to restore and get very impatient and move on from it. But it's really important to know that some people are a little bit impatient. Some people don't necessarily want to wait, and some people don't want to create that foundation that's necessary. So I think it's important to communicate with that person and let them know. But at the end of the day, if someone doesn't have a ton of compensations built up, or if you feel like that person needs immediate asymmetrical intervention, that is the way that I would probably go. Because some people, especially these laterals, hamstrings and abs aren't going to cut it right away. So give them that first, but then immediately take them into the next step, because these people do need a little bit of a sense to at least start feeling a little bit better, just a little bit of the push. In terms of oblique orientations, I would say the same thing. Sagittal, I don't see as many. I probably have only worked with like 4 or 5 sagittals that I can think of off the top of my head. I don't see them quite as much as the other stuff. So I think with the obliques and laterals specifically, those tend to be the ones that have a lot of things going on in their body. I would start thinking about, okay, let's take you out of your PR, I'd call it a PEC, bilateral forward pelvis, and then make sure that you clear up measurements enough to the point where it would probably be an okay idea to start getting a little bit asymmetrical after that. But make sure in their program that they do that stuff first before they do the other stuff. Make sure they do the bilateral phase 1 exercises before they move on and do the phase 2 and phase 3 exercises. Does that make sense? I'm working on a way that I can lay this out and make it much easier to understand than just verbally, but to play around with it. But if you're ever on the fence about it, if you're ever weary, then I would say just be really safe. Go through the 3 phases. They're there for a reason, because if you follow them, you're going to see a lot of success every time. But once you start getting more confident and more reps, you can start thinking about going a little quicker. Anyone have any questions on that? Okay.
Connor,
Yeah.
I got some pictures from different clients, so I think it would be funny to make like a assessment quiz, and special about the feet and femurs and tibias, because sometimes I don't know what the hell is going on, because there is so much going on. Sure. Can I just share my screen with you?
I can make you the host, and then you can share your screen from there.
Okay, get ready, because you are gonna see terrible things, people.
Let's see.
These are the most complicated cases I have. Well, most of them. Well, they're most okay. So let's share screen. Okay. So this is it. Let's put this bigger. Okay, this one, just to figure out if he is in a left AIC, because we can see very clear that the right shoulder is down, and he just came to me because he was complaining about an elbow pain, because he rides motorbike, and well, I think it's pretty much clear, right? And the right hip is higher. Okay, so he has been in a left AIC for a long time, maybe. And yeah, it's like, okay, this is I don't know which layer of compensation is that, if it's the 2 or it's already 4 end game, because that head is like, okay, protruding like a turtle.
I have absolutely no idea without measuring them, but we can definitely talk about what we see visually. Do you have his measurements by any chance?
No, at all.
Don't worry about it. What do you see right away? Like, what stands out to you about this guy other than the forward head, which for sure I think we can all agree on?
Well, obviously that the back mediastinum is very expanded. So he probably started as an arrow and become this breathing strategy, and that pulled him forward. Well, I cannot say much more, right?
Yeah, let's go back to the other pictures from the other views. All right, what do we see here? I don't want to do all the talking, but obviously that right shoulder is for sure lower.
Which side is the elbow pain on?
The right one, the one with the gas.
Yeah. Does anyone know why his elbow might be painful?
Valgus? I don't know.
Yeah, so elbows can valgus and varus just like knees. So this guy, I think, it's hard to tell from that image, but valgus, just like within the knee, in the elbow, it's IR mixed with ER at the forearm. It's relative too. So I think this dude has a very forward right shoulder, very, very much so. And I think that's pulling his humerus into IR. And based off of that, can we see the back view one more time?
I'm gonna meet someone. Okay.
Yeah, it looks like that could be going on. I would probably need to actually look at what's going on with his actual measurements to know for sure, but he could have a situation where that tibia is relatively turning against that humerus. And that could for sure be leading to that elbow pain. I think this back is the most telling picture out of all of them. I think you can just literally see his right elbow hanging lower than his left. And I'm always going to look at the waist crease too. So you can see that he has an indentation on his right more than his left. That's probably obvious, but I'm always going to look for that. Other things I'm going to look for is what his hairline is doing in the back, which, I mean, if this guy's like totally just standing neutrally, then his head is cranked to the left, like really cranked to the left. Also, you look at his belt line, his pants line, his underwear line is always very telling. That's always what I'm going to look at as well. And you can tell it's on a slope up to the right. So based off of this, I don't think this guy would have a lateral orientation. I don't think he would have an oblique orientation, but that's obviously not a 100% guarantee. But my mind is already going to sort of like an exaggerated left AIC, potentially a sagittal orientation, potentially just really, really locked up, but underlying all of that is just a normal human.
Okay. Very nice.
You guys have any other notes that we see here?
Yes, this one, especially the feet. I have never seen such a feet like that because they look like, okay, they are, there's no arch. I just put him on their toes and heels rising every time in every exercise to rise those.
Person.
And it's like, well, he was a former soccer player. And
how tall is he?
Tell me.
How tall is he?
How tall? Yeah, 1.85 m or so.
Literally no idea what that is. Can anyone convert that to me?
6 foot, 6'1".
6'1". Okay. Yeah. He has some incredibly stubby legs for someone who's 6'1". You guys seeing that? Like it's like his calves are the same size as his legs. But he's not like small. That's amazing. Okay. That's just an interesting observation, but keep going.
Okay, so we see that the femurs I obviously externally rotated, but the tibia should be internally rotated in order to achieve such a lack of arc. Or if we see it from the back, yeah, it doesn't seem that it's very, very, the calcaneus is not very, I don't know if it's everted or inverted. I mean, it's not in valgus of their feet, right? It's just the tibia is in IR. Fin.
If you look at his Achilles, it's hard to see which one is a little bit more bowed, but it honestly kind of looks like his right one is a little bit more bowed than his left.
Mm-hmm.
Like kind of that C shape.
Yeah.
Let's take a look at the arches individually.
This is the right.
Mm-hmm.
And this is the left.
Left arch is higher than the right.
Yeah.
You see how his little toes are just going in so hard?
Yeah.
Yeah. That guy is for sure. Is he wide or narrow?
He's definitely a wide.
Definitely a wide. Okay. Can we see some upper body pictures?
Yes.
Okay.
He hasn't the total knee extension because of an injury. I don't remember if it's the right or the left. Maybe the right, I think. What is the other one?
Left waist crease is higher than his right. So what do we think? This is interesting. This is a good one.
His left calf is bigger and his left shoulder looks a little higher to me.
Yeah. If he's just standing neutral, his left foot is quite significantly behind his right foot. I don't know if he is though. That could have just been like one of those things where that caught him in that moment, but that's not actually how he stands. Yeah, I think his left hip is higher based off of what I'm seeing in this picture right here. It's not significant, but I think what's interesting is, can we go back to the side profile of him?
Of course.
It's almost like he's got a little bit of sway back.
Yeah, because he lacks lower lumbar.
He's got negative glutes. He has negative glutes. They're just not even there. It's a flat line from his low back all the way. You got a little bump, but then you see just a total cliff.
Mm-hmm.
What kind of issues does this guy have?
Well, knee pain, sometimes low back pain, this tight butt syndrome.
Mm-hmm.
So it's weird because if he's a white, he shouldn't be. Well, if he has got the external rotation from his femurs, then piriformis and stuff is gonna be tight, right?
Mm-hmm.
Well, I mean, this man is like a piece of wood, and I train a lot of rotation with him.
Yeah.
Because,
Do you know what his measurements are like?
Not at all.
Okay.
Because if I do the assessment with 80 clients, I just get sick of thinking. This is also this woman was asking me, okay, because what can I do in order to decrease my belly volume?
Oh man, she's sucking in.
Yeah, she's sucking right now, and I was just telling her that when she exhales, because I just get rid of this common explanation or order for the clients to say, okay, bring your belly back inside and up, like Pilates style, and I just do very normal breathing, nose breathing, and full exhale until you feel your obliques. Okay, so I just told her that his lower abdomen and probably pelvic floor is not contracting synergistically. That's why we keep on seeing this. And also, she's very, very compressed. I mean, she. Okay.
Yeah, that's dramatic. That's dramatic.
Yeah, she has a lot of pain. Well, she improved a lot too, but when she just go to toe touch, his back is this. Okay. So she's very, very compressed, and also, she has a lot of she has a lot of breast, but it's also a consequence of this kind of expansion of the mediastinum, also anteriorly but also posteriorly, right?
Yeah, this person just has a massive rectus strategy. No doubt about it. That's one thing we can say for sure. When you see like that indentation and it's just massive, and you see that, like I saw in that previous where her hand was on the wall, just like that tent in her mid upper back, that's a huge indication of a rectus strategy. Do people know why that is?
Sorry?
Do we know why the rectus strategy is resulting in that tent in the upper back? We talked about this in week 5, but it's been a while. Basically, the rectus is like one of the last things to go. It's like one of the last, like people tend to like always have a degree of tension in there relative to the obliques. But once we get to the point where we're just pretty extended, or like whatever that is for the individual, the rectus will like tighten and then pull down like this, which I can't even do it very well, but that's what creates that tent-like sensation. That's why it's like this little protruding, this little like Hunchback of Notre Dame thing a little bit, but it's very isolated. It's not like a smooth curve. That's a rectus strategy.
Okay.
Like that.
Well, let's keep on with the horror. Okay, and these fits are like, okay, wow. There's a bunion. also from the back. I know I apologize for the lack of quality of the pictures because there is no light at all, so it's pretty hard also for me. But she says she's like massive hyperlordosis. I mean, and this what you see is her belly. So she's so compressed posteriorly. She's I think she like almost every short woman started as an arrow, but yeah, she became wide because the guts just pulled her ribs away. And we spent like 20 or 30 minutes of the class just doing 1990 bridges, stand lion, okay. And it's like, okay, they improve during the class, but if they don't do the exercise at home, they come just, well, they improve, but it's very slow, I would love to see these women with less curvature and a little bit less of organs protruding. And it's like, okay. Also, we see if we look at their feet, they are probably externally rotated and then internally rotated, so that becomes this lower arch. Am I right?
What do you guys think? Someone else talk besides me.
It looks more the opposite to me.
Really?
Like
okay.
IR femur, ER tibia.
Yeah.
Based on this picture.
IR femur, ER tibia, and then
yeah, that's just what I see.
I would agree.
Okay.
Why does she have those bunions?
Why?
Anyone can answer.
Late stent.
Heels, because she wears stilettos.
I don't know, but
has worn stilettos for a long period of time.
What's the most obvious reason why she has a late stance foot? Two main reasons.
Their weight's forward, like she's tipping forward.
Yeah. The other one, and this is just something to consider, is she's relatively overweight, and that matters. So if she is going to carry that gut, then it's going to be hard for her to sense, like the hamstrings need to find leverage to pull all that excess visceral fat back, like that's, and this isn't judgment. This isn't anything that we're saying is good or bad. This is just something we need to consider as coaches. So helping her potentially through like a fitness program, actually like shed a little bit of that will help her over the long term pull that back a little bit. But that's not to say that she couldn't do it without that. It's just something to consider because she has so much pulling her forward.
Thank you, man. Well, okay, we have here the typical representation of a true narrow boy, okay? And he has previously he works as a hairdresser, a stylist. I think you can guess it, okay? And his right shoulder, the one he's working with all the time, he's when we with pain or without pain, we make correctives, but he doesn't like correctives. He wants to get like 2 boobies here, delta is like, I don't know, he's taking not asteroids, but he's making, I don't know, taking something. Okay, she's with the dietist from the center where I work in. And I just said to him that the maximal thing I can give him is, okay, so a 6-day split and 1 day of legs, because typical man that he doesn't want to do legs at all. And any recommendations to, I don't know, convince him that if he doesn't do alternation, if he doesn't do different correctives, he's gonna get injured and he's gonna feel like crap afterwards.
I think the best corrective you can give this guy is a cheeseburger. So student needs to gain some weight. Do you have any other pictures?
Yeah, sure. I don't have assessment here. No, they're all everything pics. These are some correctives in order to, because he's always with this orientation of shoulders, and it's like, okay, if I do a bench press with you, I'm gonna, but he doesn't have pain. So it's only when he does overhead, he feels that kind of click, which improves when the shoulder is in front of the body. But when it's like in this orientation, then it's like click, click, what do you think it may be causing this sort of pinching?
So when the shoulder, are you measuring flexion? Like what's the deal with, is it like when it's in low levels of flexion, high levels of flexion, higher than that? Like what are we talking with that clicking?
I think he's over 100. It's not bad at all.
So let's say you were doing a shoulder flexion assessment and you were to go here, and then about right at this point, they would get the click in the elbow. But if you were to take them out here, they would not get that.
Good question. I will try to do it and I'll tell you.
Yeah. But generally speaking, that clicking, it's not painful clicking, yeah?
No.
Yeah.
He just said he just is pretty much paranoid. Okay. So sometimes he just worries about, the clicks of the knees, the clicks of the shoulder or the elbow. But no, not painful at all.
I think he's just probably, once you get to 100, he's probably just going into IR. So that elbow is probably going to start rolling out at that point. So once you get here and the elbow starts to roll out, that's IR happening. God, there's so much glare. I'll fix that in a second, but that's IR happening. And he's probably just moving fluid around within that joint. If it's not painful, it's probably just a click. It could be his actual shoulder joint. It could be the AC. It could be really just anything in there. It's hard to say, but I would imagine that dude just probably doesn't have the posterior expansion because you can tell his back is pretty flat. And also you can kind of tell in this position right here. This is actually an interesting picture. Look at his mid upper rib cage. There's like a little bit of like a concavity in it right in there. Yeah. But the rest of his back is flat. Now, that could be because his arms are overhead. That could be the scap posteriorly tilting in the high levels of shoulder flexion, or it can be a representation of a compressive strategy he has back there. But it'd be hard to say because his arms are very much overhead, almost in full.
I think I like to always, not assess static, but also with an exercise. And every time I try to put him on an exercise, for example, in this one, she's doing like a tricep extension, okay? But because he doesn't have proper stability or I don't know, motor control, he just pulled his chest forward, like arching the upper back.
Yeah, I mean, this dude with this guy, anything that you do with extension of the humerus with this guy, I would put him over like an exercise ball, so that his chest is over an exercise ball, so that he has to have thoracic flexion. And then anything like you're doing your I's, T's, Y's, whatever you're doing, just do them on the exercise ball so that he's over it. So that and then put your hand on his back and say, if you lose the tension on my hand, then you're extending and you're compensating. That's how I would get this guy to just sort of not extend with any sort of humeral extension.
Okay.
Anything else you wanted to hit with this guy? Yes, he'll just extend in that position, which isn't the worst thing ever because he doesn't have a lot of pain. But also, like if you really want to improve his mechanics, then I would get him prone over an exercise ball.
Okay.
Does that make sense?
Yeah.
Cool.
Okay, just two more. Okay, pretty quick. This one just a fit. Okay, he came with the right psoas complaint. Okay, I just tried with him right out of the gate, the right glute max and the left adductor, and he felt like crap. Okay, so then because it was before the week of the whole process, and then I saw, okay, first step, glide variably, all right, and then I put him on quadruped and 1990 and so on, and do some planks, and he just improved just by improving their abdominal compliance. And
Yeah.
about the feet, what do you think, guys? I don't know if this one is better.
First picture looks different than the second. Can you go back to the other one?
This?
Yeah, show me the other one now. Yeah, it's interesting looking at go back to the top one. Yeah, so I mean, that's clearly the guy's got bilateral tibial ER. That left foot is desperately trying to find pronation. I wish we could see the foot arches more individually, but it looks like the left one, go back to the other one. It looks like the left one is quite high. So this guy's probably narrow, and he bypassed mid stance, started in more heel strike, just like most narrows do. And then they bypassed that, went to late stance, toes went out, left side, bigger propulsive strategy. Yeah. And you also, it's hard to see what the femur is doing here, but that left tibia is just cranked out, and you see the big toe really crawling towards the midline, especially on the left. That's that left foot just trying to push and pronate.
Mm-hmm. Okay. And last but not least, he's a runner. Okay. And we got here pretty much a lot going on. Okay. I see, like, okay, here's the problem, you know, the left feet shows a lot of so when we see that the side of the feet is protruding, having thought an arch, it could be like well, and following his whole leg is like internal rotation of the tibia, right?
Let's see him from the front.
Naro, what are you, man?
First picture, top left. Oh, let's go back two more. The one in the very first image there. Very first image in the yeah. You almost had it. Left, top left. Very yes, that one. Yeah. There we go. Okay, so the left, yeah. The tibia does point out, but you can see it kind of goes downward and inwardly there. So there's a difference. I'm glad you have this picture, because there's a difference between a pronated foot and a collapsed foot. This is a collapsed foot, because pronation is, there's relative motion between the forefoot and the rear foot. Now, that's why I've actually been having my clients get a lot of Gary Ward's wedges lately, just because I really like them. But real pronation, like a pronation drill for Gary Ward, is to elevate the lateral heel and the first two toes, because this is pronation right here. It's relative motion, but it's not this. This is not pronation. That's a total collapse of that foot. Now, that guy for sure would have some issues, I'm sure, doing anything like running on that left side. I'm sure that would give him some discomfort. If it doesn't, I would be surprised. That right side has a bigger toe gap than the left. So what could be going on with this right foot?
Because so right foot could be in early stance, and the other one would be also in early stance, but not so much.
Yeah, I think the right is in more early. I would agree with that. I just think this guy probably doesn't have a very big arch to begin with. So I think that right arch is definitely flat. I think he's early entering into mid. So with this guy, I would for sure want to get hit. I want to take care of that left foot. That's something I would look at immediately. Usually I don't care about the feet that much at first, but I want to know what they're doing, but addressing them directly and prioritizing that is something I would do with this guy on that left side.
Okay, yeah, I just categorize him also in a left AC. So I try some asymmetrical exercises. Well, I see him in a month, so I don't know how it's going to be, but I just make, for example, a lunge, focus on pushing with his right leg forward. So he learns to propulse with the right but on the left, I just tell him to a more yielding strategy. So it's split lines, left leg forward, and I just make him drop quick down, but trying to break, to stop with control. And I don't know if that makes sense, or I just make the whole crap mistake.
I think if you gave him a heel elevation on the left, like a left heel elevated split squat, sometimes when you have a late propulsive foot, sort of like that, he's sort of like mid, late-ish, but I would just give him a heel elevation because that foot has nowhere to go. It's going to basically just collapse. So I would give him just a heel elevation to start off with. That'll help him get some good ER and expansion back in his life too. And I would just kind of start there and see how his foot adapts over time to see if it improves. If it doesn't, then I would still just focus on clearing him first through the first phase and then see just kind of what happens. But I think the foot will and it should progress with the phases. But if it doesn't, then that's probably something that needs to be looked at a little bit more in isolation.
Okay. Yeah. Okay. Thank you very much, Connor.
Of course. Does anyone else have any client pictures or anything? Or any client cases in general? Anything come to mind? We could take one of. Oh, go ahead, Jonathan.
I wouldn't mind doing like being a case study.
Let's do it. Yeah, let's do it. All right.
So,
let's see. We can switch our view to speaker view if you guys want to get a closer look at Jonathan. But yeah, let's have you just stand nice and neutral.
Okay. And also it's like, so real quick to, I guess like to like set the scene. So like I'm a pretty good mover, but I feel like I have very distinct things that could serve like as a good case study. Can I go through those like just real quick and then? Cool.
Yeah.
So I have like a little scoliosis. I feel I could be in my right hip, but I always feel like I'm in my left hip. Like if I look at my posture, I'm actually the opposite. If I feel my erectors on each side, my left side is much bigger than my right side. So I'm sure that indicates something. I think I talked about this earlier. My scaps completely wing. My shoulders always used to pop out. They don't anymore. But scaps still definitely wing. I can get all the way down into a squat, no problem. I mean, it probably helps that all I've been doing is front squats with kettlebells for a year because I haven't done anything compressive because we haven't had a gym. So I can get all the way down into a squat, but I have no ER or IR in either of my legs. Like it looks like nothing.
Interesting. You're narrow?
So I thought I was wide. We had this discussion early. So like maybe also because like I've been learning this stuff and only doing certain expansive exercises for such a long time now that like I can get into a squat, but squats used to feel like shit. So that could have something to do with it. Feet, very, like I played soccer forever, bunions like crazy, toes pointing wrong way. Maybe this could tell something if I go into like a child's pose, I have like no ability to plant or flex my feet. Like I can't actually get my like shins to the ground. So there's that. And then if I do like a lot of push-ups or if I ever did barbell bench press, always like medial epicondyles, both sides get tender. Those are like the issues that I have. Like nothing that like crushes me, but like I feel like they all tell a story. So that's it.
Okay, thanks for that. Yeah, let's do a visual, then we'll actually assess you.
Sure.
We'll do both.
So what are you looking for a view?
Would you be comfortable going shirt off? It's totally fine if you're not.
Yeah, totally.
Sweet.
Keep that on. That was my hair.
All right, stand nice and neutral. I'm gonna flip you to speaker view so that I can actually get a look. All right, team, what do we see?
I have a question.
Yeah.
Did you get any concussions when you played soccer?
Probably at least one, yeah.
Okay.
Okay.
Yeah.
The day before the SAT, so that was cool.
Why you asked, Tyler?
There's definitely some funky like cervical and visual stuff going on, I think.
I'm pretty sure I have Duane syndrome. Do
Can
know
you
what that
explain what that is? Sorry, I've never heard of it.
is? Yeah, so I can't look to my right. One eye will like completely, oh, no, I can't look to my left. So this eye will just like go do its own thing. These glasses are prisms.
I was gonna guess that, dude. Oh my God. Okay.
Okay, so
That
yeah.
explains a lot to me.
So essentially,
I
but this was all my life since I was like 3. Essentially,
Yeah.
I double vision. I see 2 images like this, and for all my life, I just like focus my image, but it just strains my eyes. So these glasses put the image together like that.
Interesting.
So
Yeah. So sorry, just to explain why I say that, it almost looks like your body's going one way and your head's going the other.
So I have to look like this a lot.
Yeah. And it's like your visual system is driving your entire posture right now.
Yeah.
That's the only reason I say that. And just the way that your eyes move when you talk and when you're reading stuff, they don't look like they work together very well.
I hate reading.
Yeah.
Yeah.
So sorry, I'm like hijacking this whole discussion, but
I want you to take this. You take this.
I don't know how much this is telling us with your prisms on standing. Like you're gonna do funky stuff no matter what, because you're so driven visually. So if I were approaching this, just if you were my client, I'd want to get in contact with your optometrist or whoever gave you the prescription, and just ask them what they're trying to do, because I don't know whether correcting your vision is driving your movement down below or not.
I only started actually wearing my glasses like a year and a half ago. So I would always correct the vision on my own, but I'd have super long days at the gym, and by my 7 p.m. client, I'd have to cover one eye, like when I'd write stuff down, because like I would just be double vision. I wouldn't be able to focus my image anymore.
Yeah. So these changes you're talking about, like I used to hate squatting, and now I can drop into a full squat, and I thought I was this, but it's that. It's like these are all adaptations to your visual system driving you. And just things that gave me a clue, just so you guys know where I'm coming from. And it's like when you watch people's eyes when they read, it should jump a little bit. And yours look like they had trouble jumping from word to word. I don't know. It's just like when you look at enough people's eyes, when you talk to them, it's like you just pick up on these things. I don't know.
When you read, it feels like it's tough. Yeah.
Yeah. So what you want to see, so what I usually do is I usually do the finger test. And what'll happen is people have trouble, like when you transition, they'll have trouble going with your finger. It's like they'll go past your finger and then overcorrect. And that's just the vibe I got when you were reading. And then the other thing that told me, it confirmed it when you stood up and your head was kind of going one way and your body was going the other. But the way that your jaw is shaped, it's very narrow here. And that tells me that there's just like something just like keeping you kind of compressed and together in your head and neck.
Okay.
So that's the 2 things that gave it away for me. And that's crazy that you have prisms, because that was the first question I was gonna ask you, is what kind of glasses are those?
I mean, everything you've said, you pretty nailed it like within 10 seconds, which is crazy.
So I don't know how much any of this is going to change your movement besides like a transient slight increase of range of motion.
I mean, just in terms of the movement, like the stuff that I was listing, it's just things that I notice. And I just feel like the more like you can learn about yourself, then you can then like put the pieces together for other clients and other people you're working with. So that's why I just thought I'd like talk
Yeah.
about.
But the tough part is that you're not going to present like any of your clients because you have this super unique thing going on with your vision. And I had the same trouble. I had like wisdom teeth surgery in high school that I was affected by like crazy. And then I played college volleyball and I had trouble like tracking the ball with my eyes. And like PRI never really worked for me until I went to vision and started doing the visual integration exercises. And then my program like cleaned up like that.
Gotcha.
So I think it'll be super interesting to do like a posture assessment and go through the assessments, and then we can kind of relate it back to vision if you guys want.
One of my best clients is actually this big time optometrist who has big time optometry, just like practices all over the country. So like probably talk to him, see what's going on.
Yeah, definitely.
Yeah, but I'm happy to do the assessment or whatever you think would be useful, whatever you guys think would be useful.
Tyler, why don't you take them through the assessment and then give us your lens through the vision stuff? Because I've never taken a vision course, so I think this is your wheelhouse.
Okay, cool. So I would just do the static posture, and we can just do like a normal posture assessment. But if basically what I see is that it looks like you're getting pushed to your left and your head is pushing to your right.
So it's pushing to the right. Yeah. Okay. So I guess like from the back. So I'm like, I feel like I'm like here.
But it doesn't look like a normal left AIC at all. Like there's some weird, like your shoulders do, but your lats don't. So that's what really, when there's mismatches like that, that's when I go cervical and vision. But basically it looks like what's it called? Like in some stroke patients, they get this phenomenon where they're always pushing to one side. And to me, that's what it looks like.
Stemming from vision.
Yeah. So now stand up again and try and close your eyes, and then try and just stand statically. So now when you breathe, like, I don't know if you guys see, but try and keep both eyes closed. And now it looks like you're pushing to your left, and your left rib went up, and now your left side's expanding more.
So when I closed my eyes, I felt more weight I felt weight come off of my left foot and then go on to my right foot.
Yep, so that made you into a left AIC, which is what we want to see. We want to see visual changes not make you neutral, but we want to see them put you out of your compensations. So now try and take your glasses off. Look at the camera and then turn your head to the left and right slowly.
Am I looking at the camera though still?
Yep.
So that's not going to work.
Yeah. Okay. Yeah. So I think what you need, just based on those assessments, it's like whatever we see in your screen is going to be fake. You know, like every single range of motion measurement, it's not going to be a reflection of your true system until you get your eyes working together better. So if you were my client, I'd say we can't really do anything until you see a behavioral optometrist.
Holy shit.
And what you can do though is that's just me being like, this isn't my wheelhouse.
But this is cool though. Like, this is great.
So what you need is your eyes to work together better. And I don't know, like, that's obviously I'm a PT. So I'd send you to somebody because I don't know whether the intervention that'll help you is visual correctives. In other words, I think correcting your vision makes your posture worse and vice versa.
And correcting my posture would make my vision worse because then it's harder to see.
Yeah.
Yeah.
Because when you take your visual system out of it, you're way over left AIC.
The second I closed my eyes, I started feeling my right foot more.
Yeah,
Yeah.
I'm
Yeah.
gonna jump in real quick for Jonathan, because I've had issues with my eyes my whole life, and I actually just got into. Connor knows this, of course, but I started. I spent a big chunk of my life not wearing glasses for whatever reason. Then I basically started. I had trouble putting the contacts in, so I was kind of like on and off with the glasses. And it's only like this last year I actually wear the contacts consistently, and my left eye is a lot weaker than my right. So I think I'm 1.00 and I'm 1.25 on the left. So my left eye is obviously weaker. But do you ever wear contacts, for example, or what's your prescription like?
For me, I never wore contacts, and again, I never wore glasses until like a year or so ago. And I always had, I think, like 20/20 vision. It was just that the eyes didn't work together.
Right. Okay.
Yeah.
Yes,
So
it's beyond my knowledge then, man.
yeah, and it always made sense. I also way back trained like this big time like neuropsychologist, and he said, because I've always gone back to school like a million times. It's like, for someone who's always in academia, it doesn't make sense that you don't like to read. I never likes to read. He goes, you must have an eye problem or something.
Mm.
That
Yeah, because you just get
that,
fatigued.
It's exhausting.
Yeah.
Just the more that we learn about this course and the natural asymmetries of the body, I'm realizing that like with the eyes, it's no different. Like most people I speak to who they can't feel their left heel, or they have all these compensations built up on the left side of their body. It's no coincidence when I asked them about the prescription, that left eye is also not doing too well either. But just a little observations on.
Yeah. So I move okay. I guess I just can't see okay.
Is your prism? Are there prisms in both sides?
I think so.
Okay.
Yeah.
Yeah, because the normal, I mean, if you go to an optometrist, they're going to say, I'm going to make you see better. And they don't care how it affects your vision or how it affects your movement. Yeah, it absolutely could be a sphenoid issue, but it's all driven visually. I mean, it's like the visual system will trump everything, basically. Right. Like it's tissue that directly connects to your brain. So it's like, yeah, like a shittier left eye is absolutely a pattern. And, I'll never forget Ron Hureska said, like your eye can get scoliosis, right? Like it's astigmatism is just scoliosis of the eye. So
why
go ahead.
So I understand from I guess like an asymmetrical perspective, like that all makes sense. But why would something like wigging scaps? I guess that affects the spine, or also like the fact that I have no ER/IR in my legs, but I can still get all the way down into a squat. Like that doesn't, and I don't feel like I'm overcompensating somewhere else, but like I understand where that would come into play.
Yeah, that's what I mean by you won't be like any of your clients ever, because
great.
When you have visual dysfunction, you'll just do weird things. Like it doesn't matter what the weird thing is, it'll just be weird. And I'm sure you could relate it to something somewhere, but I don't think anyone's done that yet.
Gotcha.
But when I've worked with people with visual issues in the past, and I'm saying like 3 or 4 people in my career, it's super frustrating because I'm like, why won't your like dorsiflexion get any better on your foot that has a plantar fasciitis? And then we talk about this lady's glasses, and she's like, yeah, I have a prism lens in this eye. And then she went back to her optometrist. They replaced the prism and made it balanced or whatever. I don't know what they did. But then her foot pain went away. And then I was like, oh, okay. I didn't have to do anything.
Gotcha.
So when I work with people who have these visual issues, I know that I'm not going to affect the system as much as affecting their vision will. So that's why I'm like, we need to find some way to get you out of your visual compensation so that we can start working in your movement without your visual system like tying you down.
Gotcha. Super interesting.
So try a squat and a toe touch, and then we can go from there.
Squat.
Try doing that while looking straight ahead. And then try a toe touch, just like feet together, touch your toes.
He looks compressed on his lower back, right? Maybe from L1 to, what do you think, guys?
Yeah. I mean, nothing to me really stood out there where I would focus on. Do
Like I
you
said-
want to try the hip rotation?
Sure.
Yeah, I think that'll be interesting if you say you have no hip rotation.
So you want to seated or lying down or what's best?
Do it lying down with like your feet facing the camera. I think that'll be the best view.
Is that a good enough angle?
Yep. And then try the other side.
It's like 10 degrees of ER
Hmm.
on both sides. Maybe right is better. What do you think?
Yeah, I mean, that's just super locked up. Now try doing it with your eyes closed. Or take your glasses off and put your hat over your head and keep your eyes open. So
Oh.
like, yeah. And then try the other side. And then try a straight leg raise on each side, eyes open. So like take your hat off.
Eyes open, but hat on here.
Do hat off first, and then we'll do hat on after. I don't know what you guys saw, but when he put his hat on, I just saw less of a straight leg raise on the left, which is interesting. Like the left side got tighter. And that's kind of consistent with what happens standing. So let's try this. Stand in like a staggered stance with your left foot back and go glasses off. And then try to force yourself heavy on your left foot.
So left foot back.
Yep, exactly. Round your back a little bit, reach your left arm forward, and then right arm just slightly back. Just like that. Now bend your left knee and then really try to put your weight on your heel more. What do you feel?
Left hamstring.
Okay. Put your feet a little closer together. And then bend your left knee a little bit more. And then pull your butt to the right.
That way?
Yeah. What do you feel now?
I mean, I still feel left hamstring.
Yep. So exhale and drive your left shoulder down to your left hip. Not too much, just like sink into it.
Little left oblique.
Good. Now keep your eyes straight ahead. Now try and turn your head to the right, keeping your eyes straight ahead.
Do I keep going?
What do you feel? That's fine.
No real difference there.
Okay. What about if you try to look at the camera while keeping your head there? So think like nose to the right, eyes to the left. Are you able to do that better now?
Yeah.
Okay. Hold that and breathe, but try not to breathe out of your mouth. Breathe through your nose. Keep your tongue on the roof of your mouth. And then tell me which nostril you feel more airflow in right now.
I think right.
Okay. Take your right hand and plug your right nostril and see if that changes anything.
And that's my left eye.
Okay. So, so it's an issue right now of pressure in your palatine bone, and the pressure's going up and out. Did it kind of feel like your left eye was about to pop out a little bit?
Yeah.
Yeah. So the pressure's going up and forward in your skull when you breathe.
Okay.
So
wait, hold on. This is weird. So I have like just like nasal breathing issues, like I'll mouth breathe and all that. And I feel a lot of times like just congested, whether it's here or here. If I try to pop my ears, air comes out.
Yep. Yeah. So yeah.
Okay.
So when you try to like pop your ears and you create pressure here,
What's
there's
that?
no when you try to pop your ears and you create pressure basically out, right?
Yeah.
There's no seal here probably on either side. So you're gonna have a tough time nasal breathing because you're gonna have a tough time with tongue on the roof of your mouth.
Okay.
So now put your tongue on the roof of your mouth and open your mouth wide. Good. Okay. So that's not a problem. So if you opened your mouth wide and you could only open it like that much, then we'd say, okay, definitely now nothing is going to work. But now we can say your tongue has the mobility to create that seal.
Okay.
So go into a long seated position.
Do you want a front view or a side view?
A front view is fine. Now we're going to try and create that seal, but we need reference through your sit bones. So try to find your sit bones in the floor as best you can.
Mm-hmm.
And I want you to think of your left sit bone like your left heel right now, so you can't lose it. So go into the same position, left shoulder down.
Okay.
Left arm forward. Yep. Right arm back. Now make a suction with your tongue on the roof of your mouth.
Mm-hmm.
What do you feel?
Mm-hmm. I think I could breathe a little better.
Yep. So hold that there, do 2 breaths. Then reach your right foot forward and pull your left foot back. So you're like shifting into your left. Don't lose that left sit bone. So what we're doing here is we're creating reference through the sit bones, and the hamstrings are lengthened. So that's going to pull his pelvis under him. So we don't have to worry about that hamstring being on because it was on eccentrically. It wasn't on concentrically. And we know that because when you do that left stance, you should feel only glute. When you feel that hamstring, you know that it's going further into an anterior tilt, the hamstring trying to wrangle it back. Now try to reach your right hand behind you like this. Take a full slow exhale and just let that left shoulder sink to your left hip. So go the opposite way, left shoulder to left hip. Good. Now go right shoulder to right ear, so your head's just kind of like upright, and just breathe in this position for a little bit. There you go. Now switch feet and switch arms, and just do one breath in and out here.
So
You feel how different this is? This is like super easy.
So this guy's going down. This guy's going
Yep.
up.
Not up, but just back.
Back.
Yeah. And you want to feel right sit bone, and just feel like how easy this is. Switch again.
Mhm.
So go left hip back. So make your right foot longer than your left. Yeah. Exhale slowly, sink into that left side. Do you feel expansion in your right upper chest?
Yeah.
Good. Okay. Now tongue on the roof of the mouth.
Mhm.
Good. Now go into that left stance again. So standing, left foot back, and see if that feels different.
So this guy in here.
Yep. And you're going left knee slightly bent.
Okay.
Left hip back. So kind of sit back to that left hip, left arm forward. Good. Now pull your left hip back into the right. So you're kind of like facing the zipper of your shorts to the left.
Facing zipper of my shorts. Like that.
Yeah. Yep. What do you feel now?
So now it's more into the glute.
Perfect. Now get your left arm as long as you can without turning your body. Tongue on the roof of the mouth, nose right, eyes straight. Does that feel different than before?
It's possible. Which is
Okay,
good.
just breathe. Tongue on the roof of the mouth, breathe through the nose. Left shoulder down to your left hip. Even more. Good, butt back into the right. Good, relax. And then try your hip rotation one more time.
You mean this guy?
Yep. Just
so-
normal. Yeah, just normal. So you can, yep. How's that feel?
I feel like I have a little more ER, IR, maybe a little more, but not a ton.
Okay, try the left side again.
I mean, that's a lot. IR's a lot more.
Yeah, I'd say.
ER more, but not great, but definitely more.
And then try standing static, and then we'll see if that changed anything.
There's a cat that wants to leave.
How's that feel?
I don't feel like I'm in here anymore.
Yeah, it looks like your head and body are going in the same direction now. Try eyes straight, and then just turn your head again and just see if that feels different. Oh yeah.
That's crazy. I mean, it's not perfect, but I would have had to close my eyes, reset my image, and have the image go back like that if I was looking. That's wild.
So you have a palate bone plug issue, and you have trouble like getting airflow through your left nostril without pressure going everywhere. And I don't know whether the eyes are driving that or that's driving the eyes, but balancing out your nervous system with that left nasal airflow is going to be huge for you.
That's wild. because that's literally every problem that I have all put together, whether it's allergies, breathing, vision, and then like biomechanical.
Mm-hmm.
That's wild.
So this is just PRI cranial resolution. If you guys want to take this course, it's unreal. It's super good.
My head feels lighter.
Yeah. It's just gaining, like, how do I put this? It's like we anchored your left side down and then just had you experience air through this left nostril.
Uh-huh.
And it's affecting your midbrain, right? It's like affecting like subconscious resting and just experiencing balance there.
Right. Because if I breathe in hard, that just collapses.
Yeah. So one technique they teach in that course is you literally just like lying in your back and put an earplug into your right nostril and just breathe.
So hold on 1 second. So lying on my back.
Yep. Put either like an earplug or like a cotton ball in your right nostril.
Okay.
And just breathe. And that's just going to get you to experience that nasal flow on the left side.
Got it. Let's also talk after this.
Yeah, definitely. Because like one huge mistake that I see people make about PRI is they think that it's all like pelvis and ribcage mechanics. And as you get deeper and deeper into it, like you start taking courses with Ron and he starts telling you things and it makes so much more sense as to why he doesn't care about people trash talking myokinematic restoration. Like he doesn't care all about that because he's like, it's never been about that. It's always been about midbrain and like cranial movements.
That's wild.
But without a left hamstring, you're not going to get left nasal airflow.
Gotcha.
That's why it goes so much deeper than just like hips and rib cages for you. I mean, I'm not saying that this is like the thing you should do with everyone.
Not gonna.
But
yeah, not able to do that yet.
But when you have someone whose sensory issues are to the point where they need like prism lenses or like when you just get reps with it, you just recognize certain characteristics of people that tell you that they're very sensory driven or like top down driven.
So assuming if I have 20/20 vision, would the idea be that I'm not to wear glasses? So are those glasses like orthotics essentially? Like they're just kind of putting a Band-Aid on things and they're not solving any problem.
The problem they solve is that you can see better, but they also tie you down to your compensatory patterns.
Got it. Yeah.
So
I feel a lot different right now.
Yeah. But if you put your glasses back on, you probably just go back to the old pattern, which is fine. Like, I'm not saying that it's a bad thing, but if we use you as a case study and just like went through the normal stuff, everyone would be confused because nothing would work and you'd look different than any other pattern that we would see.
Gotcha. That's crazy though.
So yeah, you're welcome. It's just crazy that it just so happened to be you that, had the issues and went, but those things stuck out to me pretty early. And it's one of those things that I couldn't necessarily tell you why at the time, but I was like, something's not right here. This is weird. It's just reps.
Gotcha. That's wild. Thank you.
So this is combining the 3 phases into one or something. I don't know.
That was awesome, Tyler. Thank you. That was tremendously helpful. Like even for me, I learned a lot watching you do that. So that was really cool. Really good way to send it off, I guess. Do you guys have any questions for Tyler on any of that stuff?
Tyler, I got
No
a question.
problem.
How often do you see people like that? Because I know it's not everyone, but like, and I know you're a PT, so you see a lot of like people. Everyone has something wrong with you a lot of times, but how often do you see like something that's not explainable down here? It's
Not
cranial.
often. Not at all. Like less than 5%, 3%. The vision thing, I've only seen, like, I can count on two hands how many people I've seen with that. Usually these people are like, you know, I've tried everything and nothing has worked kind of thing. So I don't look for it, but when it presents to me, I'm like, okay, we can't go to the normal stuff.
Damn, that's cool. Thanks.
Yeah, and that's the thing, right? Is like the advanced PRI courses just allow you to help that 5% of people that didn't respond to the other stuff. And that to me is the value of going deeper into it. Like, you can help the majority of people just by doing the basics that we covered in this course. But then there's that small subset that need the other stuff.
That's crazy.
Yeah, I tell people that for everyone that we work with, you know, like we're trainers, and a lot of us are. We have some PTs, but most people are trainers. So there's like a scope of practice thing to consider. And there's also just, you know, like it gets to a certain point when it's better to refer out to a professional like Tyler. So I always tell people that like about 90% of people will probably see success. And then there's going to be some people that don't, and it's not, let's assume it's not a compliance issue. Those are the people, just like Tyler said, it's like 5-10% somewhere in there. You just see nothing and nothing gets better. And then that's when my brain starts to churn. So that's a great point, Tyler. Does anyone else have a question for him?
I have a quick question.
Yeah.
One of my clients, she's 13-year-old and has a pretty large right rib hump. And she actually, I don't know if that has anything to do with it, but she can't close just her right eye. She can close her left eye and keep the right eye open, but she can't close just the right and keep the left eye open. She has to close both if she closes the right. I just want your opinion on that.
That's somebody I would definitely send to behavioral optometry, because that's the perfect age for them to do their thing. And
Yeah.
it's just about, it's about getting the eyes to work together better. And I don't have the skill set to do the specific like visual exercises and apply those well. I can do the stuff like we did today. You know, it's like it really came down to that it's not necessarily a pure visual issue, right? It's like a neurological, like cranial one. But for someone who's that young, they would benefit greatly from seeing a behavioral optometrist. And that's where I would go to. Because I mean, stuff like that, if you can get it early, is really correctable. Mm-hmm. It's a lot harder when you get to it later. So when I see stuff like that, I don't say that I have the answers for it necessarily. Like, I try stuff like we did today, like, oh, let's just see how these things improve with it. But that's when I would refer out for sure.
Would you say that like one or the other causes the right rib hump, or the right rib hump messes with the vision?
Well, the right rib hump is just a reflection of the system, right? It's just a system that's stuck to one side and rotated. Don't think of these patterns as like musculoskeletal. Think of it as neurological, and our measurements and the reflection of it that we see is just musculoskeletal. I mean, if you think about like what asymmetry stems from, it's not necessarily that there's a liver on the right and a heart on the left. That's what people just say. It's that we're all inherently driven by our left brain, and some of us have a better connection to our right brain than others.
And I have one more question that's more selfish. If you look at my eyes, my left eyeball is kind of more like that. This is exaggerating it. And I'd also love to hear your opinion on that.
Yeah, that's just a right TMCC pattern. It's just a sphenoid that's tipped.
Okay,
So,
I haven't heard TMCC yet. I've heard superior. Like I went to a PRI guy and he said superior T4.
Yeah, so superior T4 is going to describe like airflow in your rib cage. TMCC is just the right BC in the head.
Okay, cool.
Yeah. So when you have this, like your sphenoid like this, when it's tipped to the left, it's going to tip down.
Okay.
And that's, I actually have a client right now that has the exact same issue, but you can see it happen in real time. And you can literally see his eyeball move when you like clear up his left hip IR. It's the craziest thing I've ever seen. But his eye droops and closes on the left when he gets really patterned. So for you, it's going to be figuring out where it's driven from, like if it's pelvis, rib cage, or cranial. And it's just going to be test and retest for you. Yeah, but it's basically a left AIC, right BC up in the head, and you're seeing it as a left eye that's down and closed or drooped.
Cool. Thank you.
You're welcome.
I have a quick question. Is it okay if I ask it?
Yeah, it's okay with me.
All right, yeah, because like I don't know if like you have to go. It's just about like has anyone here ever like worked with someone or they themselves have injured or strained their QL like area like on a deadlift? I'm asking for a friend. Myself.
Very frequently for me.
Okay.
Which side is it?
It feels like prior to it, I think I was just overtraining and trying to just PR all the time, like every day, because it was just a way of relieving stress. I was starting to feel it on the right side, and then now I feel it more on the left, but it's a little bit more like I'm in a lot of pain right now, actually. To tell you the truth, like it hurts to cough, it hurts to sneeze, and I'm just really concerned that I like did something like terrible. But yeah, it's more so like on the right. Yeah. Anyone can take it.
I just suggest going to like someone to assess it. I mean, it's hard to say, you know, like acute things need time, but like go to like a chiro, like they're great for that kind of stuff. If you know like a good chiro or something.
Yeah, you know what?
A client that's a chiro, actually.
Perfect.
Yeah.
You know what?
Go ahead, Phil.
Yeah, because Tyler just mentioned chiros, and I've been working. Connor's like my 5th coach right now. Okay, that I've been working with for a bit over a year, or like closing in on a year. But on my journey with coaches and like this whole left AIC, patho PC realm, I was working with like chiros. So I wanted to know like from Connor or just anybody in the chat. You know when you're stuck in an orientation, right? And then you see like all these strongman competitors, these powerlifters, they're constantly taking trips to chiro. I never got the chance to ask Connor this especially, but what's your thoughts on chiropractors?
Tyler, you want to go? I can answer it too.
Yeah, I'll go. There's good ones and bad ones. I mean, it's like anything else really, but for acute stuff, chiros are great because like sometimes acute stuff resolves right away, but you just need pain modulation, right? So I know that Amy knows how to do all the like correctives and whatever 90-90, and she knows how to do those. But if they're like, I used to work with a guy in Boston that I trusted, because if somebody like flared up the right QL, I'd be like, go see this guy. He'd do whatever he does, like manip or like Graston. I don't know. I'd send it to him and people would feel better. And then I could be like, okay, I'll take over from there, whatever it is. But just beware, if you go to a chiropractor, they do a quick assessment and they give you like the 6, whatever it's called, like the 6 cracks. It's like boom, 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 boom. See ya. That's the only thing you have to look out for chiros. But there are some good ones out there for sure. It's just about trust in practitioners, and it's like PTs, you know, it's like you could go to a really good one or you could go to a bad one. And I'll leave it
Yeah,
at that.
but I just have a lot of trouble believing that, like, it's like the assessments we do, right? And there's the 3 phases, and you see, okay, this person's lacking this much shoulder flexion. They have all these boxes that need to be checked out, and then it's like you have one of those same guys who we did the presentations on. Then they go to a chiro because maybe they hear it's good for them, and then what? The session lasts like 5 minutes. Just, you get what I'm saying?
Yeah.
Like I don't buy it. Like, I think there's way too many boxes to be. I think it depends what the person's issue is, but I have a hard time believing that's gonna like change the orientation that they're in, or like at least have like some
it's
long lasting effects. It's like static stretching. Like, what's it really doing? You know, it's like we're not changing the way they're breathing. We're not doing anything corrective. It's like, I'm not knocking it, but I don't. And I watch a lot of like strongman powerlifters, and I noticed that they're always taking trips to Cairo, and it's just like crack this. They're out in 5 minutes. I don't really, not knocking anybody who did Cairo, but I don't see how that's supposed to change the orientation, and like, how is that supposed to put us? It's like if we're stuck in extension and our calves are tight, and then it's like the equivalent of doing that and like just getting like a calf massage. It's like, we're not changing the orientation. Like, we need to get us back on our heels. I kind of look at Cairo the same way. It's like, yeah, you may have some quick relief. It might feel good for a day or two, but it's like, how many Cairo visits you're supposed to take? Are you supposed to do this thing for the rest of your life? Like, what's the long-term approach?
That's why I'm saying for Amy, like, I know that she knows this stuff and she has it down, but acute pain is going to change the way that you move acutely. And chiropractors are really good at pain modulation in the short term. So like I said, sometimes acute injuries take a little bit of time to resolve on their own. But if there's techniques or whatever, you know, strategies they have to lower pain in the meantime, that can be valuable for, you know, a visit or two. And then you can kind of take care of everything else on your own after that. So
Also,
by
That
all
was kind
means,
of like
you
the
know,
question. It's like, I guess that's when you would recommend a chiro. If someone wants like the short-term relief, maybe it's like a week out from a competition or something. Like, is that it?
Yeah, and it's also like, because I have professional relationships with these people, and I could do the pain relief stuff, but I don't really want to, and I also want to drive that professional relationship between us two. So that's when I would say, like, go to a chiro. But if there's any practitioner you trust, whether it be a PT, chiropractor, you know, osteopath, whoever it is, yeah, if they're like a manual therapist, then that can help for the short-term pain relief stuff. But it's by no means like a long-term solution. So like anything else, you know, it's like, it's whoever you trust. And if you're already doing the other stuff, if you're doing like the 20% of things that make you 80% better, then you can do the stuff that people knock. You know, you can do the foam rolling or theragunning or whatever. It's not that these things don't work. It's just that there's bigger rocks to fill. And then after you do those things, and if you still have pain, then yeah, theragun the crap out of it. It'll probably feel better. So
yeah, I feel like with a theragun, especially, it's more psychological, you know. It's more, I think it just has like a placebo effect where it's like they feel good for that moment. It's like, oh, you know, Kind of
You know
like
what?
the
I
side
call
switching.
Theraguns meat tenderizers. And I tell my clients that they've wasted their money and to throw them away because it's a short-term solution. And I know I'm not
But
supposed to like, take things away from people, but like I don't want them to develop like this mindset of like, this is my quick fix. Because I'm just like, you're just tenderizing meat with a Theragun.
Yeah, but short-term solutions have their place too, you know? I mean,
Right.
like I just know that everyone who's in this biomechanics coaching group is going to probably know a decent amount of stuff and how to help people through the biomechanics part of it. So if you were just XYZ person, I probably wouldn't recommend a chiro, but I know that you know your stuff and you know how to take care of the long-term issue that's causing your problem. But in the meantime, it would help to have some sort of short-term technique to modulate your pain so that the long-term stuff can work better.
Right. Like my intention is to, I don't think it's a postural thing. I think it's just a result of just overtraining and just doing too much, just pulling too much load. But yeah, like as far as like the like modulating like and treating the pain, I've noticed that like if like inhalation like when I'm really emphasizing like a really long inhale, I do get relief in that area with a very extended inhalation. Don't know why. That's why I defer to you.
Know.
Why is that? Oh, shit.
It's just, I don't know. It's just pain modulation. Like it's really hard to say without, looking at everything. But if a strategy works for you, why not use it? It's not hurting anything. It's like, if scratching your right earlobe makes your pain feel better, then scratch your right earlobe. Just know that if you tell somebody to do that, it probably won't make their pain better.
Okay. Yeah. Just I would just notice that like the very extended inhalations just really, really help the pain experience. So I didn't know if that had anything to do with the workings. So, magic.
I'm gonna head out, but I just want to say to everybody, and especially Connor, I appreciate it a lot, and most likely going to be taking this course again. Then I'm going to take the beginner course. I'm going to get from there. I'm going to go to the advanced course. But I really feel like after these 12 weeks we just had, like my toolbox is way sharper, and but I'm most likely gonna have to take the course again. But
It's been a pleasure, Phil. I've loved having you in, man.
It's crazy, man. Yeah,
always fun having you in.
Build some connections, I invite anybody to follow my Instagram. I'll follow you back right away because I like seeing like the posts you guys make. Considering you guys just finished the same course I just finished, and I'm following a couple guys, a couple people, Amy, Be Original Coaching, a couple people, but yeah, I'm really happy, man. Just more tools in the toolbox, it's just, and there's certain tools that like, I have all these I have like hundreds of lifts now, hundreds of extra exercises. I have maybe a dozen assessment drills. I have probably like dozens and dozens of prep drills to just plug and play. And there's certain drills I may never even use, but just the fact that I know that I have them in my arsenal, it just makes me feel that much more confident as a coach,
Of course, man. Of course. And you've gone through it yourself, which is especially important because if you can do it on yourself, that is always what makes a really good practitioner, because then you know what things feel like, you know what the progression feels like, you know what the frustrations of the highs and lows feel like. And I think that is going to make you such a better coach. So keep doing what you're doing, man.
Yeah, man. And it's not the, I know I mention this often, man, but it's not to put any kind of coach down, but like, I guess it's because when you see what mainstream fitness has come to, it's like so flashy, and I'm willing to bet that like if you were to take most of these YouTube influencers, which is there's nothing wrong with being a YouTube influencer, but like these are the people who get a lot of like the eyeballs, and I'm willing to say that like a lot of these guys, if you were to just give them a client who has a hip shift, they wouldn't even know what to do with someone like that.
No, yeah.
They would have no clue. And
Yeah.
it's just like, it's sad because it's like, that's kind of what fitness has come to. But like, it'd be cool if like, you know, if the concepts Connor and like all these, you know, the Hartmans and like, could become more mainstream, you know, where it's like the norm, where it's like, okay, a coach sees a guy with a hip shift, he knows what to do about it. A coach sees a guy with he's an X orientation, we know what to do about it. But like, I guess that's not the kind of content people want to consume, you know.
Yeah.
Until it's their time to like
Right.
really need that kind of content. But I can understand the perspective of somebody who doesn't have these, they're not put in these crazy orientations where they're not going to have the same need for it.
Yeah. No one really cares unless it affects them in their life. You know, that's pretty much why that's why I try to put out content that really strikes home with people, you know, because I want people to say, that's me. Therefore, I'm interested in what this person has to say. But yeah, man, you hit the nail on the head. I always have said that if I was a generic personal trainer and I didn't know anything that I know today, I don't know if I would like my job very much. And that's because I wasn't getting results with people. I wasn't making people better and helping them accomplish their goals. So yeah, just trying to spread the good word.
You know, nobody cares about like ACL post-ops, cancer, COVID, like all these things until it happens to them.
Right.
Then they become like the experts. But
yeah,
anyways,
I totally understand, man.
Appreciate it, man. Take
Appreciate
care, everybody.
You guys have anything? I got to head out soon too myself. Do we have any final thoughts before we wrap it up here?
I just want to say thank you so much for putting up with me for a second time around and allowing me to take your course for the second time. I know it can be really annoying and stuff, but just really thank you so much. It just enriches my knowledge, and just thanks. Thanks,
I
everyone.
mean, you're an OG. You're one of the originals. And guys, like I said in the message I sent this morning in the Slack chat, just because this course is over, I'm not a stranger. I don't want you guys to feel like you can't contact me if you have any questions about anything. There is an open line of communication, and you can always message me with any sort of questions, qualms you have. Give me some context, and then I'd love to help you. I might start that Slack chat group very shortly as well. So also, one more thing, I'm going to compile all of these videos together after this one is done saving, put them in a YouTube playlist, shoot it to you guys, and then probably take the website membership down in the next couple of days. All right, guys, appreciate you all. Thank you. Thank you very, very much. Honestly, really enjoyed this. This was an amazing time. Have a good one.
Love you.